Welcome to the Power of Telehealth in Primary Care, Policy and Practice Update for Pragmatic Adoption and Integration across the Care Continuum. My name is Merlene Tucker, and I'm running this Dialogue for Health web forum with my colleague, Kathy Piazza. Thank you to our partner for today's event, the Lung Cancer National Training Network at the University of Louisville and the Bristol Myers Squibb Foundation. It is my pleasure to introduce Celeste Worth, the moderator of this event. Celeste Worth has over 20 years of experience in cancer control and provider education and is the director of the Luca National Training Network at the University of Louisville. She is also a tobacco treatment specialist and a master certified health education specialist. She was previously a co-investigator for the provider education component of the KY Leads Collaborative and the Professional Education and Training Manager for the Kentucky Cancer Program at the University of Louisville. Celeste, welcome to the microphone.
A lot of valuable information from this presentation. First, I want to share how Luca National Training Network at the University of Louisville can be a free resource for you. The Luca National Training Network, which also goes by Luca, is funded by a grant from the Bristol Myers Squibb Foundation. In addition to providing education and training directly to providers and other health professionals with webinars such as this and an online course that you'll get access information for later, we also provide assistance, materials, and other resources for those who are educating health professionals in primary care on topics related to those who are at risk for lung cancer or who have been diagnosed with lung cancer. Next slide. Our website at lucatraining.org recently received a national award and has over 300 tools and resources for both providers and patients. We encourage you to check it out, and please contact us at the email on this slide, lucatraining@louisville.edu, with any questions or requests. We are very honored to have today's speaker. Dr. Joelle Fati is an adult primary and acute care nurse practitioner and a certified tobacco treatment specialist. She has dedicated her clinical career to integral roles in general internal medicine, thoracic surgery, pulmonary medicine, lung cancer screening, and tobacco cessation. She is an associate teaching professor in the Department of Biobehavioral Nursing and Health Informatics at the University of Washington School of Nursing. She has spent over 20 years providing direct patient care and serves at local, national, and global levels as a leader in healthcare and expert and advocate in tobacco control and telehealth. Dr. Fati is committed to prevention and early intervention of chronic diseases while optimizing health outcomes through patient outreach, education, and comprehensive care delivery through technology. She has served as the Program Director of Telehealth Clinics, Director of Nursing Practice and Health Policy for the Washington State Nurses Association, and a member of the Washington State Telehealth Collaborative. Dr. Fati is the lead or co-author of numerous publications, including Nurses Advancing Telehealth Services in the Era of Healthcare Reform. With that, I will turn the microphone over to Dr. Fati, and we very much look forward to your presentation.
Well, good morning. Thank you very much for your time and for a special thanks for submitting questions. People submitted some excellent questions, and I did my best to address almost all of those questions in my presentation today. So thank you, and thank you for your time. Today we are going to explore telehealth and how and who it may serve, but we're also going to discuss how policy is currently influencing adoption and dissemination, and we'll also cover some examples of application of telehealth and where we go from here. There are so many definitions of telehealth out there, and we could spend probably 30 minutes discussing those, including the distinction between telehealth and telemedicine. But I think that our current circumstances in this country and around the world really beg us to examine what this really looks like on a very broad level. And I really love this definition by the World Health Organization, mainly because it's very inclusive and all-encompassing, and it's comprehensive in its mission in regards to healthcare, while bolting on technology as a consideration to reach and improve healthcare for the most vulnerable in our communities and beyond. So you will get access to this slide deck, and I hope you take some time to let that definition marinate. You know, I always like to start at the beginning, and you know, telehealth is not a new concept. Telehealth has been around for well over 100 years. It really started with sending heart tones by telephonic connection in the early 1900s. The concept of a physician reaching out of a screen and connecting with families to deliver health care was evidenced on Radio News magazine in the 1920s. This concept of two-way visit has been around forever. And meanwhile, you'll see across our timeline that in the 1940s, 1960s, we had the invention of closed-circuit television and the ability to send communication by satellite, caring for our astronauts in space. And psych mental health visits were some of the first to be conducted by remote connectivity. And then, you know, for many of us on this call, we can definitely remember the invention of the World Wide Web and the explosion of internet expansion and email conception. And we all enjoy high-speed internet connectivity currently. Many of us do. But what we know is that there are volumes of people in this country who do not have that connectivity. The Federal Communications Commission has been charged for a number of decades in addressing this issue. It's been slow, steady but slow, and really at a snail's pace in reaching people who are in some of the most rural areas. And it's difficult to believe, but true, that about 68% of Americans are in rural areas. I'm sorry, that 68% of Americans who live in rural areas still have very limited broadband coverage. And even if they have coverage, it's not capable of conducting telehealth visits. And this is a real burden and a barrier to delivering telehealth services. Some of the major challenge in expanding this broadband coverage is really financial. And this has become a more acute upfront issue in the current pandemic state, and increasing resources are being allocated to closing this digital divide. So it's a very functional time for us in regards to creating more access. We have volumes of people in this country who are geographically isolated and medically underserved. So 97% of our country is designated as rural territory. Now, that only represents about 19% of our population, but it's still a big swath of land in this country where there are medical providers that are attempting to close the gap of geography and deliver health care. But as you can see on the map on the right, the very dark blue illustrates the areas that the country is really suffering from health professional shortage areas, including remote Alaska. This is a real problem in getting people the health care that they need. Meanwhile, we have very large swaths of areas in this country that are suffering poverty, and that is illustrated by the very dark maroon color on the map. And those really closely overlay with those areas of medical professional shortage areas and also the rural areas. But what I want you to also know is that our urban companions are also suffering from poverty. And if you take a look at these statistics here, 11% of those living in rural areas suffer from poverty, but actually people living in the urban areas are also suffering poverty. And many of them also are uninsured, do not have access to internet, and there's even greater numbers of children in both rural and urban areas that are impoverished. And what this equates to is if you combine this rurality with poverty levels, we're looking at a much higher mortality rates. So this is these are a bad combination for people to experience. The locality and poverty combined carry this exponential risk and implications for mortality. But certainly the people who are living in urban areas who are experiencing higher levels of poverty are at about the same risk of mortality as those who are living at the lower end of poverty in rural areas. So my point here is that people in both urban and rural areas are in need. They're underserved, medically, economically impoverished, and are in need of telehealth services. So with that, we have our first polling question within the presentation. If we could bring that up. So the question is, which of the following are drivers for the adoption of telehealth? A, aging population with chronic diseases. B, healthcare workforce shortage. C, falling healthcare costs. And D, dissemination of technology. The majority of people selected the right answer, which is A, B, and D. Okay, so while considering our rural and urban patients who are living in these areas who are experiencing 5 times a greater risk of mortality, we really need to consider what the causes of these diseases that are harming them are and how that interfaces with telehealth. So tobacco-related diseases, including stroke, heart disease, COPD, including lung cancer, but also chronic illnesses such as diabetes, suicide, and unintentional injury are placing people at much higher risk. These are all significant illnesses and disease states that can be prevented, and certainly early intervention can be utilized using telehealth to support people in their health. So health services are determinants of health, and limited access to health care, lack of health care coverage, and limited English proficiency, no matter where you live in urban and rural areas, are barriers to getting the health care that you need. And this leads to unmet health needs, delays in receiving appropriate care, and inability to receive preventive and preventable hospitalizations. But there's also changes in healthcare that are driving the need for telehealth. We have a aging population with multiple chronic diseases, a healthcare workforce that is dwindling with volumes of healthcare providers who are either retiring or not entering the workforce to begin with. We have challenges in regards to dissemination of technology, but we also have a push for cost containment in this country. So there's a real shift in provision of high impact and quality care. Historically, the fee-for-service reimbursement models where services were unbundled, they were paid separately, and financial incentives were more based on quantity of care, have really shifted more towards reimbursement models that are pressing towards what we would call a pay-for-performance model or value-based purchasing. And this is where clinical care reimbursement is, the services are bundled. You're paid based on expected costs of caring for that individual, and it's very focused on quality of care. Now, quality of care is can have a different meaning for many, And I've spent a lot of time thinking through this. I really appreciate the IOM, the Institute of Medicine's definition, because I think it really aligns with what we're aiming for in regards to delivery of care by telehealth. So what quality means is that we provide safe care, including services that are most likely to benefit the patient and avoiding harm in our harmful interventions. But it's also providing care that's respectful and responsive to patient preferences. It's reducing wait times and harmful delays and providing services that are evidence-based. It's also providing care that doesn't vary in quality because of personal characteristics such as gender, race, where people are, including urban or rural settings, and socioeconomic status. So this framework really promises to meet the current reimbursement demands, in my estimation, and more importantly, to meet the needs of our patients. And I think that telehealth is really perfect for this in meeting these quality aims. So before we move on to the next section of our presentation, another polling question. The technical term originating site is used when describing the location of the patient in a telehealth encounter. True or false? So about 50% of the participants in this poll chose the correct answer, which was true. The originating site is identified of where the patient is. And this is often a term that is utilized especially when discussing reimbursement for services. The distance site is where the provider is in the telehealth relationship, no matter where they are. Okay, so another polling question. Which of the following are accurate statements about telehealth? It's the use of interactive audio, video, and electronic media, used for the purpose of diagnosis, consultation, or treatment of a patient, includes asynchronous transmission of patient medical information, or all of the above. Okay, and 100% of the participants chose the right answer, which is all of the above. Thank you. Okay, so there are many modalities, potential modalities for care delivery by telehealth. One is what we would refer to as the synchronous live audio-video conferencing, where it's in real time and the patient is interacting with a healthcare provider. This can also occur in the asynchronous setting, which would be more considered store and forward in your bottom right-hand screen. This is where we use technology to transmit patient information. That could be images, radiologic images, or perhaps pictures of skin conditions, and they are sent to the distance site for the provider to review and respond to. Increasingly, especially in this pandemic, mobile health, also known as mHealth or virtual care, has been picking up, and that is more of the synchronous setting, live audio-video conferencing by a device. Interprofessional e-consult has been around for quite some time, and this has been really useful for professionals within the healthcare community to work on clinical care together, cases that may be challenging, and interfacing with one another on that consultative care, perhaps from a rural originating site to a specialty provider at in an urban setting at a perhaps tertiary quaternary medical center. Telephonic is one of my favorites, and you'll hear a little bit more about that later in the presentation, but we can't forget the use of the telephone. It's such an excellent way to connect with people. And e-home care or remote patient monitoring as well, which has really taken off in healthcare. Home monitoring equipment really supports our care delivery in telehealth, and this is often provided by equipment that is advancing as we speak. if you take a look at the devices on the right, these are devices that I used in telehealth clinics, including Bluetooth-enabled wireless stethoscopes. So literally, patient out on the Olympic Peninsula, and I can listen to their heart remotely with my stethoscope that is Bluetooth connected. And honestly, these cameras that can be utilized for ophthalmologic exams and looking at skin lesions and wounds and in the mouth are bionic. They're just sometimes more than you want to see and hear, but they're pretty incredible. The home monitoring equipment is really advancing, and there's technology like the tablets in the middle of the screen that are connecting to our home monitoring equipment and more interactive with patients and sending messages to providers real time. So it's just really exciting to see this advancement. This home monitoring technology and care delivery has been embraced, and healthcare providers are able to charge for and get reimbursed for various types of monitoring. And this has been really critical for patients and providers in not only diagnosing, but also maintaining adequate, optimal, and appropriate treatment for patients. Project ECHO is a concept that was born out of the University of New Mexico Health Sciences a number of years ago. And really, this is a concept that was built to support providers in rural areas that were not only isolated by geography, but professionally isolated without access to their colleagues, and often caring for clinical conditions that are quite complex and may be out of their wheelhouse, so or their dominant training. So Project ECHO is really sort of this concept of case-based interaction where rural providers come to the table and meet with specialists in urban areas or at academic centers and have an exchange of information. It's really been a great way to develop providers in the field and to deliver a higher quality, more efficient, effective, and timely care to patients in the rural areas. But there have been some although we've really had sort of this exciting, innovative leap forward in terms of our technology, there have been some pretty significant hurdles in dissemination of telehealth until our pandemic of late. So historically, limitations have been imposed on originating sites. So basically, the patient could only be seen if they were in a designated facility or in a health professional shortage area in order to receive services. And meanwhile, services provided were really limited to provider types and only certain services. Furthermore, policy that was largely inconsistent across payers were significantly limiting in terms of the types of services or the modalities of telehealth that we could provide. So largely the provider had to be at a medical facility providing care at the distant site to the patient at the originating site, and the patient could not be at home. They had to be at another qualifying facility in an HPSA. Home monitoring is not always consistently covered. It depends on what kind of home monitoring it is, but that has been expanding significantly. Store and forward has not been consistently covered, and telephonic for sure has not been historically covered. So there are barriers when it comes to policy, but there's also barriers historically with patients and providers in adopting telehealth, including gaps in technology knowledge, lack of confidence in technology, patient-provider anxiety and ambivalence in using telehealth, and just general inexperience with care delivery by telehealth modality. There are also major federal, state, and regulatory barriers to advancing telehealth. And we could have a whole hour on just discussing the variations at a state and local level, as well as that federal level. But the three major limiting factors have been lack of payment parity for in-person versus telehealth visits. So basically, there's been inconsistent or no reimbursement for telehealth services compared to in-person services, or a much reduced reimbursement for services by telehealth. Also, there's been limited interstate licensing, so this has been a real challenge in regards to providers being licensed in one state and working to deliver care across state lines, but not having licensure in that other state. And this is, again, managed state by state, and there have been many challenges across all health professionals, which also include dentistry and veterinary medicine, et cetera. So these are all areas that the states and the government have been working on, but haven't really come to a standardized or unified agreement or plan on this. We have another polling question. So the question is, state and national policy are not dominating influencers in the adoption and implementation of telehealth. True or false? A majority of our participants got the right answer, which is false. State and national policy are definitely dominated by a number of influencers, including Centers for Medicare and Medicaid Services, state Medicaid, federal policy, providers of healthcare, professional regulating bodies, state policy, and private payers. So with healthcare systems that have developed into the complicated and sophisticated settings that they are, healthcare centers and payers are especially involved in healthcare spending. And as this spending has increased, their priorities have shifted to quality care at an affordable price. And everybody is really interested in the interaction between policy and facilitating telehealth and advancing telehealth, but certainly within the considerations of what it's going to cost. There are national telehealth champions that have been very involved in the advancement of telehealth, including the FCC, which we talked about earlier, that implements and enforces U.S. communications laws and regulations and getting broadband access out there. But there's also the Congressional Telehealth Caucus. This is a bipartisan congressional committee who are solely tasked with advancing telehealth. And they really set out some great telehealth priorities to expand access to telehealth and remote monitoring, especially in the rural areas and underserved communities. And also the Office for the Advancement of Telehealth. They are always working to increase and improve the use of telehealth to meet the needs of our underserved people, but also including folks who are underserved and uninsured, including those who are enrolled in Medicaid. And I think it's really important to point this out because this work was very fortuitous. The Congressional Telehealth Caucus was working on prioritizing this Connect for Health Act way before COVID hit. And this was really looking at expanding coverage for telehealth services, waiving certain restrictions, including geographic requirements, including delivery of services for patients depending on where they are located. But part of this Connect Health Act also included that all telehealth requirements of the Social Security Act would be waived in the instance of a national emergency. And honestly, that national emergency occurred, and the country was able to move very quickly to a plan that advanced telehealth, and I really believe that based on the work that these champions did early on, that all occurred very smoothly because it was well thought out, and we were able to integrate it very quickly. But there are other champions that have been out there and very proactive in adopting telehealth, including the Veterans Health Affairs. And so in 2018, they made this a real priority, and they lifted state licensure restrictions within the VA health system. About 25% of veterans live in rural America, and that's actually higher than the general population, which is about 19%. And in 2018, they really kind of launched this program, and by 2019, they had over really nearly 1 million telehealth visits with the vision in 2020 to expand all primary care mental health services by telemedicine. So they were already well on their way within their systems, and that was very exciting. So COVID-19 has resulted in unprecedented demands on our healthcare system and the use of telehealth to respond to this national emergency. And if there's a silver lining in any of this in regards to telehealth, COVID has been instrumental in really pushing the envelope and allowing us to understand exactly how telehealth services can support healthcare delivery. Now, there are 31 changes that support telehealth. We don't have time to go over them today. I've included in this slide deck a number of links to resources so that you can access them. But suffice to say, they are modeled after the Connect Act that I shared with you earlier, and they really kind of open up access so that and break down barriers. So licensure barriers, they have largely opened up payment across the boards for all telehealth modality types, including telephonic, which has been instrumental. They've eased the burden in regards to HIPAA penalties, which I suspect will tighten up again, but in this COVID response across the country, the scramble for technology has been huge, but also providers of HIPAA compliant platforms to conduct this healthcare have been challenging. And so lifting provisions and providing opportunities for people to use various platforms to deliver this care has been instrumental. It's also supported providers and patients in the locations that they are. It's lifted restrictions in regards to frequency of services provided, and it's been a real relief. So currently, telehealth expansion during this public health emergency includes all of these modalities of services. And, you know, one of the difficulties in advancing telehealth in this country has been that we've had a paucity of research. We have not had randomized controlled trials or even retrospective data that was hefty enough, powered enough to really help us understand the benefits of telehealth, but also to leverage the conversations with payers and policymakers to advance telehealth to the point that we need it. So another benefit to this full-scale implementation overnight in telehealth is that there should be some data that emerges along the way. And we're already seeing it in the literature. So New York University, who was hit very hard with volumes of patient visits, and we're right in the middle of this scramble for flipping overnight to telehealth, recently published a paper that demonstrated a over 4,000% increase in non-urgent care visits, with 135% increase in urgent care visits. And obviously, these are huge increases. The non-urgent care visits really demonstrate where about 80% of the visits that would normally occur in person went to telehealth. So that's incredible expansion and dissemination of services. So I think we have one more polling question here. Which of the following clinical services can be safely and responsibly conducted by telehealth? Lung cancer screening, tobacco cessation, psychiatric consultations, postoperative follow-up, or all of the above? Great. So the answer was all of the above, and it looks like 100% of the participants answered this correctly. So telehealth is a tool, and it's not for everyone. It's really to be utilized to augment care, but it does not replace hands-on comprehensive or the comprehensive nature of healthcare. So sometimes we're going to have patients who, and many times we may have patients who are just not appropriate for the telehealth setting and need to come on in. But as evidenced by these two pictures, we've got two people who are sick in bed with probably something like a viral respiratory infection, but one may have a much more complicated picture and need closer observation and hands-on care versus the other. We just need to keep this in mind when we are deciding who's appropriate for telehealth. So I wanted to give you a couple of examples of clinical care that I've experienced as a nurse practitioner. This includes where I was located in a tertiary quaternary medical center in Seattle, Washington. It was a relatively large thoracic surgery practice, mostly oncology patients, 5 surgeons, 2 pulmonologists, 4 nurse practitioners, 2 nurses, 1 medical assistant, and 5 schedulers. So a pretty broad, large-scale clinic. And here, if you can see the screen, the bottom right yellow star is Seattle, and the top left-hand star is the Olympic Peninsula, where we had patients in a health professional shortage area. So as the crow flies, these people were about 70 miles away, but this was a ferry wait, a long drive into the city, and about 8 to 10 hours round trip, and $60 to $80 in costs. So this was our Tele-Lung cancer screening program, and just using an example of a real patient who I saw, I conducted a remote shared decision-making visit with a woman who was 62 years old with a 35-pack-year history of smoking, who had quit 12 years ago and had some remote exposure to asbestos as a child. In that moment, I did conduct that by remote shared decision-making over telehealth because telephonic visits were not covered at that time, but they are covered for shared decision-making now, and that would have made it much easier for me. So she went to a local clinic, got her her baseline CT scan, and I was able to pull her images up on the PAC system and see her remotely in the clinic with our telepresenter. As you can see on the screen in the yellow circle, she had a finding on her imaging that was consistent with what we would call a non-solid nodule. It was quite small and felt to be stable enough to be seen in another year. At her next year annual follow-up, where again she went to her remote imaging facility and checked into a clinic out on the Olympic Peninsula. She came in and was seen in follow-up for this nodule that again was noted on her imaging. It was felt that it was stable in size. Perhaps it was a bit more darker, so we put her on a 6-month follow-up. You can see her 6-month follow-up on the left. Again, it's at that point we felt that it was a little bit larger, put her on another 6-month follow-up, and the image on the right demonstrates clearly some consolidation of that lesion. So the important piece here is that she was able to stay in her community for this cancer screening, and it was very convenient for her to be able to go back at an annual and also 6-month follow-up basis. Once this determination of a more concerning lesion was found on imaging, we were able to provide her with a remote multidisciplinary team review. So the team in Seattle was able to review her images, discuss her care. She was able to go to a local department to get a transthoracic needle biopsy, which confirmed a cancer She then came into our medical facility for a one-night stay in the hospital. She had a minimally invasive procedure, had a wedge resection or a small section of her lung taken out. This was determined to be a stage 1 cancer where she was not in need of any chemotherapy or radiation, and she was put back, returned to a 1-year follow-up schedule, and with no recurrence or new findings. So that is an excellent example of not only delivering preventive care, but keeping patients in their communities and them being able to benefit from all the resources at a remote site. Tele-Lung, so surgical management of telehealth patients. This is a case example of a 50-year-old man who I was called about on Thanksgiving Day a couple years ago. He had a 50-pack year history of smoking, currently smoking 2 packs a day, had very advanced COPD at a very young age. He was airlifted to our medical center because he had collapsed his lung due to these COPD-related changes in his lungs. I was called in to discuss tobacco cessation with him because he was going to necessitate 2 pretty significant surgeries to, in attempt to improve his lung status. So on every hospitalization for the 2 surgeries that he had, he was seen in the Tele-Lung clinic, in the telehealth clinic for his postoperative follow-ups and his workup for his next surgery. But he was able to stay in his community. His elderly parents were able to take him to the clinic locally. These people did not have resources to bring him into the medical facilities for all of these pre- and post-op visits and imaging. It was very convenient for him. But what I really want to point out is the behavioral health care that I was able to provide him in terms of his tobacco cessation, which was critical for him to achieve. So when I met him over the telephone, which I was unable to get reimbursement for at the time, he identified himself as 10 out of 10 motivated to quit, citing that he wanted to see his children grow up. He was 2 out of 10 confident that he could quit because he had not been successful in the past. And over the telephone, I was able to provide behavioral counseling and a treatment plan for him. Over the course of about 6 weeks, we were able to get him successfully quit with about 10 telephonic or in-person audio-video conferencing sessions that included some relapse prevention follow-up care. Now, I really want to point out our public health partners who have been really integral, especially during this pandemic. They're truly our unsung heroes, but I think they're often sort of, in our communities, and we don't always pay attention to the services they provide us and how they champion things such as telehealth in terms of policy development and pushing it forward. But they really come to our rescue in many different settings, including health emergencies like we've experienced today. But our public health partners could really benefit from expansion of telehealth as well, including our community health workers who are in the field reaching patients at so many different touch points. And so I just really want to recognize that and understand that efforts need to continue to get people in these areas of public health service the resources that they need, and telehealth is perfect for that. There's other modalities of telehealth out there, including teledentistry that provides screening and preventive services. We've got teleophthalmology that has been instrumental in preventive care and treatment. There's also other populations of people that can really benefit from this increased demand, including our isolated older adults, psych mental health services, even in correctional health where it's difficult to get healthcare professionals recruited. Certainly cancer care and survivorship, behavioral health, as I had mentioned earlier, chronic disease management, and also addiction services within the opioid crisis. So with 8% of our population who experience limited English proficiency that equates to about 25 million people in America. We need to really consider how we can enroll our translator colleagues. They really play a vital role in high quality care delivery, and they also have seamlessly folded into this telehealth environment and have the capability of accompanying us within our visits. So certainly worth looking into. Now, there were a couple of questions that had some significant interest in privacy and security approaches and informed consent within the telehealth setting. And I just wanted to point out some important items. One is that currently there's a good faith provision for telehealth during the pandemic. So there are a number of apps that can be used, but a few that should be avoided, including Facebook Live, Twitch, and TikTok. And then there are some recommended HIPAA compliant platforms that are listed here. Informed consent, the requirement for informed consent varies by state policy and health plans. There are also institutional policies that may also apply, and also the basic informed consent for care may suffice. So you should really check in locally with your compliance officers in your health institutions to understand what that looks like. So I just want to touch on a few more items before we leave today. One is really considering addressing education for a healthcare workforce. So while we're disseminating telehealth and moving it forward, we also need to remember that we have future healthcare workforce that we need to invest in and develop them so that they can get out there and do the good work when they are ready for that. And we've addressed this at the University of Washington in a few ways under HRSA grants that have supported us in those efforts. I want you to know that there are many different telehealth resources out there, and I've listed them here for you. All of them are really integral in advancing telehealth, but also keeping us aware of legislation and regulatory status in our states and in the nation, providing technical assistance and program support, and also providing resource toolkits and clinical, administrative, and technical guidelines. So I would really recommend that you check those out. The Department of Health and Human Services has a really beautiful website that continues to develop, and they have a patient interface and a provider interface. So I would really encourage you to check that out. Many people in the questions had concerns about where we're going to go from here. And I assure you there is stuff that is occurring real time, including administrators at CMS that are concerned about maintaining this and this momentum, but also what the next chapter will look like. And there were committee hearings just as recent as last week with the Senate Health, Education, Labor, and Pensions Committee addressing these issues. So now it's up to us to continue to advocate for telehealth, to research telehealth so that we have evidence that informs our practice and to translate that evidence to our clinical world, but also continue to build high fidelity and functioning programs and advance best practice care models so that we can transform healthcare that really embraces telehealth. And finally, I'll share with you that there are many ways to get involved at a local level, and so I would check into that, including connecting with local elected officials. And apologies for running out of time here. So much to say in so little time, but really appreciate your presence on our call today.
Great. Thank you so much, Dr. Fati, for that really comprehensive and informative presentation. While attendees have a chance to submit their questions on the side for response later if we run out of time, I will quickly share information about a couple of key tools from Luca very quickly. Next slide, please. Our previous webinars were presented by Dr. Katie Garfield at Harvard Center for Health Law and Policy Innovation. And she introduced and reviewed two new resources developed in partnership with Luca, which address coverage for lung cancer screening, as well as tobacco cessation coverage. And if we could forward to the next slide, I think people can see a quick image of those. Those publications and recorded webinars are available on our website at lucatraining.org. I'd especially like to share information really quickly about our free award-winning comprehensive online course, Lung Cancer and the Primary Care Provider. This course covers lung cancer care across the continuum in 3 separate modules and provides free CME, nurse practitioner specific credit, or AAFP prescribed credit, and is available to anyone. You can also access this on our website at lucatraining.org. And to get updates from Luca, on the next slide, please, and to learn about our upcoming webinars and other offerings, please follow us on Facebook and Twitter. We'll be sending out news of those upcoming offerings very soon. We really are not going to have time to delve into the Q&A at this point in much detail. So what we do have is what you all have submitted, both with your registration as far as when you initially signed up for the webinar, and also those that have been sent during the presentation. I will go ahead, for those who can stay on a few minutes, and just touch on a couple of those with our speaker, for those who can stay on just a little bit longer. And so first, with what we received early on, Dr. Fati, the first question is, what are the do's and don'ts in a virtual interaction, and how do I best engage clients?
That's a great question. So there are definitely some items that we refer to as webside manner, and so some of that is relates to privacy and security, so showing your name badge and evidence that you are who you are, but also having them share with you their ID so you can ensure that you are seeing the person that you expected to see. But also just having the sort of creating this environment that is professional, professionally dressed, well lit so they can see your face, making sure that you have a good handle on your technological equipment so that we can minimize snafus that can break up the sort of the flow of the visit. And that always provides sort of this sense of confidence by the patient in their visit with you, but it also just enhances the opportunity to truly connect with the patient and display whatever you're trying to convey towards the patient, including empathy, et cetera.
Great, thank you for those specifics. I think that people really benefit from the nitty-gritty level on some of this. Also, what was asked was, how do we make sure that clients have a laptop and internet coverage in advance?
So, we've seen this challenge rolling out across this pandemic epidemic, and I think that there are many things that are going to have to change in this country, including access that is affordable to such devices. And I don't know if that looks like rentals or gifts or central kiosks where patients can go in communities. I think this is an area that's really underdeveloped and something that we all need to be really kind of working on and finding solutions in our communities because it comes at a cost, but I think it's a burden that we all need to consume, and we've seen it even in our own school system locally, and there have been some amazing community efforts to make this happen. And so I don't think it's if we can do it, it's how we decide to do it, and I think it's something that needs to be quickly rolled out.
Sure. Okay. And because of time, we'll just take on one more question right now and give you the opportunity to answer others separately. But this was, how do we make sure people who live in isolation or remotely know how to use technology?
This is another challenge. And, honestly, I think that we need to, again, reach out into our communities because these people who have lack of connectivity aren't going to be able to jump on a webinar, right? They're not going, it may be that it's public libraries, it's their doctor's offices, that somehow we need to find access points for them to learn how to do this and engage in this type of healthcare. And I think there are also populations who just it'll always be a real challenge, and it will not be an option for them, including the elderly.
That makes sense, and appreciate your giving some insight on that, as all of this is a slow process for many. And also, we'd like to thank Luca National Training Network at University of Louisville and the Bristol Myers Squibb Foundation for support of this offering. So thank you all again for your participation today. We hope this was helpful, and look forward to you participating in the future.